Morning. So we'll be starting a section on oculoplasty. So this is a oculoplasty video assisted skill transfer course from lid to socket. So our first speaker is Dr. Anju Chandran. So I welcome Dr. Anju to give a talk on lid and canalicular tear repair. She is a consultant at Contrast Hospital, Kozhikode, and she has done a fellowship from Shankar Netralaya, Chennai. Over to Anju.
A very good morning to all of you. So I'm the opening batsman today. So the topic for today that was given to me was eyelids and canalicular tear repair. So I believe this is a tool that every general ophthalmologist should have in their armamentarium, and not just oculoplasty. So when you deal with a case of trauma like this, what do you do first? You make sure whether it's the sole ophthalmic event. Is there an open globe injury that you need to rule out? Does the patient have any other systemic conditions that requires an acute intervention? So as a physician, you need to make sure that you know the mechanism of injury, detailed records as to when it happened, how it happened, whether it's a workplace injury, immunization status of the patient, any medical conditions that you should be aware of. And as an ophthalmologist, yes, vision, pupil, and globe integrity. We cannot emphasize it enough and more. All this is important from the medical legal aspect as well. A photo documentation is key in most cases of trauma. So now let's go through a few scenarios here. We have a simple case of laceration here on either side. Now, how would you go about the repair? So this child on the left, he has a neat wound with no tissue loss, and if there is no tension, what we can do is you can oppose the wound with simple steri strips, or if you need a little more approximation, you can also make use of cyanoacrylate glue or tissue repair glue. Since in this particular case, it follows the Langer lines of skin relaxation, you will get a good apposition without much scarring. Now coming to the second case, in that particular child, if you see, there is fat prolapsing. So in order to know how this fat prolapse, let's look quickly at the lid anatomy. So you have the skin, the orbicularis, then you have the septum that keeps the preaponeurotic fat from coming out, and then you have the levator aponeurosis, which lies just beneath that. So when you see a case where the fat has prolapsed, you must be aware that the orbital septum has been breached, and that's why you should also look for LPS injuries and make sure that it is repaired. So in this particular child, what we did was we just excised and repositioned the rest of the fat and sutured only the skin. So the timing of repairs, it can be delayed up to 72 hours if you do not have optimal conditions, but what happens is around after 24 hours, tissue edema starts settling in, and then repair becomes very difficult and cheese wiring of tissues occurs very easily. This is a quick look at a full thickness lid margin repair. So we begin by the three lines at the lid margin, which are the gray line, the anterior lash line, then the meibomian orifices. You can repair it either by a direct closure or by horizontal mattress sutures in this fashion. Always approximate the cut edges of the lid margin with suture of your choice. Begin with the gray line always to get a good approximation. You should make sure that the bites are at equal distance and depth. And you can always secure two sutures with the help of bulldog clamps. What most of us forget is to evert the lid and look for the extent of injury, especially the tarsus. And when we repair the tarsus, you should make sure that it is with partial thickness suture bites and not full thickness, so that the cornea is not rubbed on later in the postoperative period. So once you have approximated the gray line, the next are the meibomian orifices. So if you look, you would have noticed that I have not placed a knot yet on the gray line. That was just for traction. But now I begin by putting the surgeon's knot, which is 311, starting at the meibomian orifices. Then I will go on next to the gray line and then the anterior lash line. So one should take care to keep the ends of the suture long so that you do not have them rubbing onto the cornea. So with the help of a bulldog clamp, you can keep all these three long sutures clamped together. And when you start putting your anterior lamellar sutures or the skin sutures with direct interrupted sutures, you can bury them within the knots of these sutures. The endpoint of suturing is basically you should have everted margins of the lid and not inverted ones, because when it heals, you might have a lid notch. Now look at this very palm-looking child. Okay, if you look carefully, you would think that there is no wound, but any wound where you have a medial injury, always look for a canalicular tear. This is a quick video where we begin with punctum dilatation, as in all lacrimal injuries or cases. Identify the distal cut end. Here you can see the calamari sign very easily. Here I have used mini monoca, which is being inserted into the cut end of the into the puncta. You can trim it according to the need and the ease of placing it. I like taking traction sutures so that I can see the distal end better. And then gently ease the edge of the monoca into the distal end. The next step would be to take pericanalicular sutures. This is usually taken with the 6-0 Vicryl that comes with the monoca. And make sure that you keep the tissues close together when you tighten the knots, or it can lead to cutting of the tissues. The rest of the repair is as we saw in the lid repair. So what happens if you have tissue loss? So here is where you can use a bit of lid reconstruction principles, borrow a little from the adjacent side. Here we have taken a Tenzel's flap to give the patient reasonable cosmesis. In injuries like that, or like this, always beware of what could be underneath. She gave a history of a shattered glass falling into her eye. And this is what we saw when we looked further. And luckily for her, it had just missed the globe and it was lodged onto the maxillary bone. So when you have a suspected foreign body, what do? You can always ask for an imaging. So here the imaging of choice is usually the CT scan. An MRI would give you a better resolution of organic foreign bodies like in wooden foreign bodies. So in animal bite injury, it's always a debatable thing. You are always wondering whether to repair or not to repair. But according to the CDC, it is a category 3 injury. You need to give adequate wound toileting, give rabies prophylaxis, giving anti-rabies vaccine on days 0, 3, 7, and 14. And human rabies immunoglobulin, if available, has to be reconstituted and given into the site of the injury. And later you can take up the patient for exploration and surgical reconstruction. Post-operative care is pretty much simple. Unlike cataract surgeries, we do not ask the patient to not wash the wound. In fact, wound hygiene is very important. Cold compresses can be given in the initial 48 hours to reduce tissue edema and thereby give warm compresses to ensure better healing. Antibiotic ointment over the sutures is given. Generally, face sutures heal within 5 to 7 days. Marginal sutures, we leave them for at least 10 days. And stent removal, we keep it only for a month and not more than that. If not sutured well, you can have complications such as this, where you have a bad lid contour, you have lag of thalamus, and you also have notching and cicatricial component, which will require other scar management. So the take-home points are: ensure ABC, triage and manage plan based on the severity. Most importantly, have a good knowledge of the anatomy. So with that, I would like to end my talk. It was a very vast topic. Thanks to Dr. Dona for giving me this opportunity, and also KSOS for the same. And we are also very excited to inform that we'll be hosting OPI 2026 in Kochi. The details will follow soon. Thank you.
Thank you, Dr. Anchu, for giving us a very good video presentation of lid tear. Now we have Dr. Annie Sridhar. She's HOD of Oculoplasty Department in LF Hospital, Angamali. She's a pioneer in establishing oculoplasty in Kerala. She is the first one to start oculoplasty practice, and we follow her. Ma'am, please stand.
Yeah. So why do we do socket? When do we do socket reconstruction with the mucous membrane graft? When we have a surface contracture. So this increases the surface area of the socket, and you can deepen the phonesis. And also when the socket is unable to retain the artificial eye between the lids. And also when you have a foul smelling discharge in the socket, to do earlier skin graft done. Usually earlier plastic surgeons used to do skin graft. There's a very foul smelling discharge. You have to remove the skin graft as far as possible and then put in a mucous membrane graft. sometimes. So, so you have to undermine the conjunctiva. You have to create the fornices, new fornices. So you have to undermine the conjunctiva up to the orbital margins till you feel the bone. You just go under the conjunctiva and put bolsters in the fornices which come out through the skin, and these bolsters come out through the skin, and then you tie them over the skin. So the fornices are deepened. So I selected this patient who had, she had an eye enucleated and EBRT, external beam radiation, done at the age of 2 years. And she had a hemiatrophy of the face, a sunken orbit. There was a bony contracture and a surface deficiency. And fornices were shallow. And you can see the conjunctiva was dry and fibrosed, even thicker than the normal skin. I selected this case because the vascularity will be low and we can see the whole thing unimpeded by the blood. So you can see the skin is so thick, and it was not cutting with normal scissors. I had to use a blade. She actually, in this case, stick-on prosthesis or a spectacle mounted prosthesis would have been better, but she wanted a artificial eye to be placed in the socket. So after deepening the undermining the conjunctiva, scalpel set pieces are used as bolsters for the upper and the lower fornices. You can measure the pieces by placing them on the fornices. And then 3 sutures of 3-0 ethibonds are placed on the bolsters and then taken out with a cutting needle through the skin. So here you have to keep in mind that the lower fornices are about 10 to 15 millimeters deep and the upper fornices are about 20 to 30 millimeters deep. So you are creating new fornices. These are taken out through the skin, 3 such sutures. So when you keep the bolsters inside, it will form a uniform, there will be uniform depth of the fornices. And then over 3 small pieces of scalpel set again. To prevent cut through of the skin, we tie them over the lids. Now again similar procedure is followed for the upper lid. These sutures are taken out after, and the bolsters, sutures and the bolsters are taken out after 2 weeks. Here you can see that the original conjunctiva of the patient covers only the one part of the lid. The whole of the bulbar conjunctiva has to be replaced. For this patient, I did a dermis fat graft, then that didn't take, so I think mucous membrane grafts 2 times. So now the video will go on to how to take a mucous membrane graft. So here you have to keep 5 millimeters inside the vermilion border. The vermilion border is a border that you see on the lid, and you have to keep away from the frenulum. And the maximum size of graft is 2.5 to 3.5 millimeter that you can take, and the lower lip. And the side of the cheek you can take a larger size graft. So here I am sitting at the head end of the patient and operating under a microscope. So you will see an enlarged view, very enlarged view, I think. So give a block under the mucosa slowly, and then put the lower incision first so that the blood will not impede your view of the upper incision. And in the socket you need not take a thin graft, you can take a little bit of fat, it's okay. And then make holes in the graft so that you can pull it and increase the size of the graft. And you need not suture it to the edge of the conjunctiva. Sometimes you cannot get the edge of the conjunctiva, you can just suture it to the bed. So you can see how much you can increase the size of the graft. And the medial and lateral canthi should be sutured meticulously, because there again bands can form preventing the placement of an artificial eye. So after socket reconstruction, you should always put in a custom artificial eye. Never go in for a ready-made eye, because this can produce again contracture, and it's very difficult to redo a socket because all the fibrosis happens. So it's very difficult to do a irradiated socket. So after placing a gauze piece, sometimes I don't do it, and then place a conformer, and you should always see that the conformer is placed horizontally and under the bolster. Again, if the conformer is not placed horizontally, it can again produce a contracture of the new phonesis that you have done. Always do a custom artificial eye. You can see the difference. And this girl had an eye put in later. The lids had to be painted over the artificial eye by Shiji, our ocularist. So thank you. This girl developed Fairuz. This girl later developed 1 or 2 years later. She developed a swelling over the forehead. It was an osteosarcoma after irradiation. So I think we lost her. After the putting in artificial eye, she got married. She had a child. She got a job. But after that, she survived. I know. Thank you.
Thank you, ma'am, for the presentation. And one thing we really look up to Annie ma'am is that she's so fearless and daring. She always takes up the toughest case and fearlessly does the case. That's something we learn from her. She's our mentor. So next we have Dr. Aparna KS. She will be speaking on evisceration, how to do it right. I welcome you, Dr. Aparna. She's a consultant in Chaitanya Eye Hospital, Trivandrum.
Good morning. I'll be discussing the right way of doing an evisceration. Evisceration is a surgical procedure of removing all the intraocular contents, preserving the remaining scleral shell, extraocular muscle attachments, and the surrounding adnexa. Usually it is followed by placement of an orbital implant to restore the orbital volume. Even though it is a radical procedure, our aim is to provide maximum cosmesis for the patient and to maintain a healthy socket. Evisceration was first described by James Barr in the year 1817 as a technique for a complicated cataract surgery with expulsive choroidal hemorrhage. In 1874, Noyes introduced this technique to treat intraocular infections. And in 1884, Mules described the first placement of an orbital implant that was a hollow sphere. Various indications for evisceration are infections like endophthalmitis, panophthalmitis, phthisis bulbi, anterior staphyloma, various causes of painful blind eye such as an end-stage glaucoma. Intraocular malignancy is an absolute contraindication for evisceration, and relative contraindications are severe phthisis bulbi and microphthalmia. Before starting the procedure, always make sure that the informed consent must be signed by the patient as well as by the bystander, explaining the nil visual prognosis of the condition in their own mother tongue. And always take a B scan for diagnosis, then for documentation, and to rule out any intraocular malignancy. These are the set of instruments required for this procedure. We can do it under general anesthesia, IV sedation, or a regional block. I prefer to do it under retrobulbar block using lignocaine with adrenaline. Then all the other instruments are routine for various forceps and scissors. And only special instrument required for this procedure is an evisceration scope. Then after removing all the contents, we will place an implant, then close in layers. About the basic steps of evisceration, first one is a peritomy, that is we have to perform a 360-degree peritomy and a 360-degree keratectomy to remove the corneal button, then scoop out all the intraocular contents. Then next step is a sclerotomy that I will be discussing later. Then placing the implant and close in layers. So over the years, various techniques of sclerotomies has been evolved, and the basic purpose of a sclerotomy is to place a larger implant and to give a scleral cover to prevent extrusion. The basic step is in all sclerotomy technique is cutting either a relaxing radial scleral incision or an equatorial scleral incision with or without optic nerve disinsertion. Today I will be discussing the 4-petal technique, which was described by Salesans and Sands-Lupus in the year 2007. Here we will make 4 incisions in between the attachment of the rectus muscle, starting from the limbal end of the sclera, extending to the posterior aspect where the optic nerve is attached to the sclera, then disinserting the sclera. And so we will get 4 petals of sclera, and each petal is attached only to the corresponding extraocular muscle, so that we can place a larger implant in the intracorneal space, and the opposite scleral petals are closed in a double breasting manner. So I'll be showing a video of evisceration that I have done in a 71-year-old male who underwent multiple intraocular surgeries, then a failed corneal graft with a sloughed graft. The eye is very much inflamed, so it is very bloody feel, and the conjunctiva is very much attached to the underlying tissues. So I am straightly going into the keratectomy step. Here I am making the stab incision with the number 11 blade, then extending it 360 degree with the corneal scissors. After completing it 360 degree, we have to remove the corneal button. Next step is removing all the intraocular contents. So always make sure that we have removed all the scleral remnants, because even if a bit of uveal remnants, even if a small bit of uveal tissue is remaining, that can produce profuse bleeding during the postoperative period. Then we have to clean the scleral shell with absolute alcohol, then irrigate the scleral shell. Then I am trying to separate the conjunctiva. It is very much adherent, it is causing bleeding. While making sclerotomies, try to avoid the conjunctiva along with it. Then making the scleral petals starting from the limbal end, extending to the attachment of the optic nerve. Then finally we have to disinsert the optic nerve so that we will get 4 petals. And for each petal there will be only one attachment, that is the corresponding extraocular muscle. Then the anterior and the posterior end of the petal is free. So these are the 4 petals with anterior and posterior ends are free. So this allows placement of a larger implant, so that I could place a 20 mm PMMA implant easily. Next is the closure of the sclera, that opposite scleral petals are closed with 60 vicryl interrupted sutures in a double breasting manner. Here the opposite petals are attached, and after that we have to suture the anterior tenons, then close the conjunctiva. So we will get multiple layered closure of the implant that will prevent an extrusion. Here anterior tenons is sutured with a 60 vicryl interrupted sutures. Then conjunctiva is closed with continuous key pattern sutures. And at the end of the procedure, we have to place a conformer in order to prevent the contraction, and to retain the conformer for at least 1 week, we have to do a tarsorrhaphy. So advantage of this 4-petal technique is it allows placement of a larger implant, and the double breasting of the scleral petals allows that will prevent the extrusion of the implant. Complications of the procedure are retrobulbar hemorrhage, orbital edema, dissemination of unexpected intraocular tumors, implant exposure, implant extrusion. Then at the end of 6 weeks, we placed a custom fit prosthesis for the patient, and this is the final appearance. Thank you.
Excellent presentation. Just 2 things, like when you were telling that you were not able to dissect the conjunctiva and tenons. One thing is if it's inflamed, brimonidine help. as
Okay.
a topical eye drops. The second thing is you should inject lignocaine and adrenaline, injection in the subconjunctival space. One, it gives you a hemostasis and it also separates the conjunctiva and tenons. Why is it important? I never compromise on the surface,
Yes, ma'am.
right? Yeah. So it's important to take the conjunctiva separate and the tenon separate in order to avoid inadvertent implant exposure. So these are the modifications that you can do whenever there is an inflamed socket, as you had in this. Now, regarding the 4-petal, I can take opinion from the other oculoplastic surgeons here. I used to do 4-petal when I started, and I was excited about it. But then later, I have been seeing the displacement, migration of the implant through the 4
Okay.
petals. So now I totally stopped 4-petal. This is purely my experience.
I'm doing equatorial also, ma'am. Equatorial sclerotomy also.
Right. So what I just do is like 2. When I have to keep a larger implant, so it's more safer and more confined into 2 petals of a sclera. Sometimes when you do a 4-petal and it's not sutured well, the implant can migrate either supratemporal, infratemporal, or any of the quadrants.
Yes, ma'am.
So I have personally stopped doing 4 petals. We can take opinion from the oculoplastic surgeons, ma'am.
Okay, thank you, ma'am.
Thank you, Dr. Abanna. As Dr. Fairuz ma'am has correctly emphasized, it is the surface. We should not cut much of the conjunctiva. We need to retain the conjunctiva. That's the most important thing when you are doing an evisceration. So now we will move on to the next talk. So it is minor lid procedures by Dr. Ann J.K., the senior consultant from Little Flower Hospital, Angamali. She is a gold medalist in her PG days, and she has co-mentored many fellows from the institute.
Thank you, Dr. Donna. My topic is minor lid surgery. So I'll be showing few minor surgeries which can be done without the use of much costly equipments or setup in a OPD procedure. So I'll be talking under few headings like tarsorrhaphy release, 3-snip procedure, INC with cyst wall biopsy, and canaliculotomy. So tarsorrhaphy, there are 2 types, temporary and permanent. Temporary tarsorrhaphy is also known as suture tarsorrhaphy. Indications, no need to explain, Bell's palsy, indolent corneal ulcer. It can be lateral, central, or medial also. So this is a short video of temporary tarsorrhaphy. The patient is under local anesthesia. So 30 ethibond sutures are used. I pass it few millimeters away from the lid margin, and it has to exit through the gray line, then through the upper lid. Then to prevent cheese wiring of the skin, you can use bolsters cut out of scalp vein. And the suture is passed in a mattress, horizontal mattress manner. And similarly, through the lower lid also you have to use the bolster. After that, you can tie the knot. It should be very tight, otherwise the action of levator will cause the giving way of the sutures. So like this, and tight sutures has to be, several knots you have to put, that's all. And this is permanent arsorrhaphy. Here only difference is we are creating a row surface between the lids. So here I am doing an incision at the gray line, few millimeters, 1 or 2 millimeters at the gray line where you want the adhesion. So this is central tarsorrhaphy, and same is repeated in the upper lid also. Then when you pass the sutures, what you have to take care is the needle end should emerge through the newly created row surface. Then rest of the procedure is same. And there should be a tight approximation to form a band fibrous attachment between these two lids. And if at all there are some eyelashes, take it out, otherwise it will cause abrasions to the cornea. And suture removal is done after 2 weeks, and by that time we expect the adhesions to be formed. Then when you want a tarsorrhaphy release, that is also very simple. You can do it as an OPD procedure. Under topical anesthesia, you anesthetize the cornea, then inject local anesthetic. Then you have to give compression for a few minutes with an artery forceps. You can do partial release or full release. Then you excise cut the tissue, whatever amount you require, and put ointment and leave it like that. So I am doing partial release only in this case. Then comes punctoplasty. It is a common cause of watering, punctal stenosis. So it can be either idiopathic or some infections, viral infections can cause this, or drugs, or some types of conjunctivitis. So there are various procedures, single snip, 2 snip, 3 snip, 4 snip, etc. So I will be showing 3 snip procedure. So this is the vertical part of the canaliculus, and this is the horizontal part. So what you do is, with a small scissors, do a vertical snip, then a diagonal snip, and a horizontal snip connecting the two. So this is the lower lid, and local anesthetic is injected, and dilate the punctum if possible. And if you do probing, you can rule out associated canalicular obstruction also. This is the first snip. It is vertical, and the diagonal one, and the horizontal snip connecting the connecting the two previous snips. And you can see the mucosa at the end of this procedure. And you may need repeat dilatation in following visits. Next comes INC with cyst wall biopsy. Sometimes you need to take biopsy from the cyst wall. Indications are KSOC1 at the old age, and recurrent chalacia at the same site, or some atypical features like loss of lashes, alteration of meibomianorivices, telangiectasia. And if you feel something is unusual, you have to take a biopsy also. So this is local anesthetic is injected, and ILD is everted over a clamp. And with a number 11 blade, you can give a stab incision and the site you can, here you can see a blocked meibomian orifice parallel to that. In line with that, you can cut and take out all the contents as in INC. Then you have to break all the connection septa in between. And with a small scissors, you can take a bite of a small cut part of tarsal conjunctiva along with the tarsal plate and send for biopsy. Close the eye with some antibiotic ointment and keep it padded for 3-4 hours. Canaliculitis, it is a cause of chronic discharge from the eye. So, presents as unilateral epiphora, pericanalicular inflammation and pouting punctum. So this is the pouting punctum. When you press it, you can see the concretions coming. So canaliculotomy is the definitive treatment. So you can see inflamed canaliculus here. So what you do is cut over the horizontal canaliculus, partial thickness, and you can curate the concretions from the horizontal canaliculus. So this is just to support the canaliculus, passing a probe, then do a partial thickness incision. I mean, the wall should be cut completely till you see the end of the canaliculus, I mean, probe inside the horizontal canaliculus. So now it is full thickness. Then you can milk out the secretions, I mean, concretions. And if you want, you can, with the scoop, Calacion scoop, you can take out the concretions like this. And you have to repeat it and put some antibiotic ointments or and eye drops. So topical anesthetic cream is very useful to decrease the pain in during these procedures. Thank you.
Thank you, ma'am. So this was the most easy topic, like for useful for the general ophthalmologist, which can, this procedures even can be done by the general ophthalmologist. You needn't require an oculoplasty surgeon. If you have seen the videos well, you can try it on the patients before referring to the oculoplasty surgeon. So next we have Dr. Fairuz PM. She will be talking on conjunctival tumor management. So she is the director of the Honors Specialty Eye Care Hospital, Bangalore. She has very many scientific publications and awards to her credit. She is the only Keralite ophthalmologist to be enlisted in the Women Power List of Ophthalmology. And she has got received the International Hero Award by AIOS and AAO Achievement Award and Asia Pacific Academy of Ophthalmology Award. So if I start reading her resume, it will go on and on. So I request ma'am to share her views on conjunctival tumor management.
Yeah, thank you so much, Donna. This is an amazing instruction course, and I think videos as a vast session, it brings in a lot of knowledge and, you know, to follow for the audience, and it'll keep them awake and not sleepy. So, and it's always good to come back to KSOS every year. It's a pleasure being here with all our colleagues, Oculoplasty colleagues. Sorry, it's not playing. Connect through, Anna. Sorry. Usually it comes directly. It's come. I have a connector. So sorry about this. Do we have to discuss about the previous, anyone, audience, any questions for the previous speakers? Ma'am, any comments? And ma'am? Annie, ma'am? Any comments on the previous videos? We can just have a discussion.
Can somebody give ma'am a mic, please?
there is a conjunctival shortening when you're doing evisceration and you can't suture the conjunctiva, you can put multiple incisions at multiple, where is Abarna? You can put multiple incisions at multiple levels. Then when you pull the conjunctiva, and whenever the patient is posted for evisceration, we give topical steroids also. Anyway, there's nothing else to do. So one day or something, if you have some time. And as Khairu said, bromelain drops can also clear in and all those drops. You can put multiple incision, not at one incision like this, in the fornix, 1, 2, like, and then if you pull little bit, like as I put in the mucous membrane. That is one thing.
Ma'am, what is your experience with two snip, ma'am? Two snip.
See, the puncture is surrounded by muscles, so that is why when you do simple puncture dilatation, it will close. So you just have to give some incision to the muscle. That is all I think it's necessary. If you make a large 3-snip, a large incision, I have seen patients developing watering again, because I think the capillary action doesn't work. Don't make a very big 3-snip. Just cut the muscle so that it doesn't close again. That's all is necessary. 3-snip is actually not done in European countries, I think, because you may have to put in a mini monoca later. So don't make a big incision. Make a small snip is enough. Punctal stenosis, we do syringing in the OPD itself to see if there is any block underneath. And when we are doing 3-snip, we dilate the punctum. Then we probe to see if there is any block underneath. And then just do 3 small incisions as a triangle, not a big incision. Fitting whenever, we don't do that. With one this thing itself, most of it cured. If there is an underlying canalicular block, we give injection bottles.
Thank you.
To the lacrimal gland.
I'm so sorry,
It's
Dona.
okay.
This is, yeah.
Don't worry, we are ahead of time. So I have a question to Dr. Anju here. Anju, have you experienced any betterment in having a conjunctival closure in vertical manner rather than the horizontal manner, status post evisceration?
So when you do a vertical closure, I do not have that long a follow-up to exactly tell whether the fitting is better or not as of yet. But yes, compared to horizontal, I believe vertical will give, as it heals, it will give lesser tension, and there's still a lot more of space for you to place the prosthesis within. So now I'm slowly shifting to, instead of a direct horizontal closure, to a vertical closure. Let's see how the follow-up is. Only the anterior tendons, if possible. I leave the posterior tendons intact. Yeah, and continuous sutures for the conjunctiva, usually 6-0 vicryl, interrupted if possible.
Canalic lytisane. Is it okay just to do a punctoplasty and express the material? Is it really required to go for a canaliculotomy?
Punctoplasty. Actually, if the horizontal canaliculus has a lot of collections, I don't think punctoplasty alone will help. You have to make a nick.
Like an extended punctoplasty to the canaliculum?
You
No.
mean
Yeah,
directly
like
cut into
yeah,
that?
yeah.
Then
Do
it
the 3-snip and kind of
will it compromise the capillary action of the puncta if both the canaliculus and the punctum both are cut?
All right.
I
yeah.
have not done that.
Okay, yeah. That is what I do. I
Yeah,
don't do
is
a
it?
canalicectomy.
Okay.
Yeah, a punctoplasty and widen it, and then
Okay.
express like with a cotton bud, express it. Yeah.
Do you use any curettage or something?
No, I just press it because I don't want to injure the mucosa
Yeah,
of the canaliculi. So that's the logic behind it. So with the cotton bud tip, just express it through the puncta, not a separate canaliculotomy.
Okay.
Yeah, I mean everyone has a different way of doing
I
things.
have heard
agree.
somebody injecting ointment, antibiotic ointment into the horizontal canal.
No, I don't do that at all.
I also have not done.
Yeah, right. Yeah. Sorry for the technical glitch. So I'm basically going to talk about, I mean, it's a video. You can all sit and relax. I'm not going to speak here. There is a voiceover. So these are my affiliations, and my affiliations in Kerala is Malabar Cancer Center in Kannur and Amardeep Eye Care in Trivandrum and Kollam. So it's about, well, we all know that we have benign ocular surface tumors and malignant ocular surface tumors. Benign ocular surface tumor, we all know how to deal with it, and it's straightforward. It's excision biopsy and, closure of the conjunctiva. So I'm basically stressing on OSSN, which I think it's very important. There are many simulating lesions of OSSN and how to manage it. It's a video-based format. There is audio. You can just sit and relax. I'm not going to speak. The voiceover is there.
Ocular surface squamous neoplasia, or OSSN, is an umbrella term which describes a spectrum of benign, pre-malignant and malignant epithelial lesions of conjunctiva and cornea. It encompasses squamous epithelial lesions of ocular surface ranging from mild dysplasia to carcinoma in situ and squamous cell carcinoma. OSSN is the most common non-pigmented tumor of the ocular surface. Carcinoma in situ accounts for 39% of all pre-malignant and malignant lesions of conjunctiva and 4% of all conjunctival lesions. Being the most common ocular surface tumor, OSSN, or anything that simulates the condition, are commonly encountered by all practicing ophthalmologists. Recurrent lesions tend to be more advanced and aggressive, but this can be reduced to less than 3% with appropriate management protocols. Hence, it is important that it's not overlooked, misdiagnosed, or mismanaged by the treating ophthalmologists. It is postulated to arise from the limbus extending to conjunctiva and cornea from the transition zone. UVB ray exposure is one of the most important causes of the pathogenesis. OSSN most commonly presents as unilateral limbal lesion in the interpalpebral area. Bilateral presentation is most commonly seen with systemic association such as xeroderma pigmentosum and immunocompromised patients. The conjunctival lesions can have varied appearances such as nodular, papillary, gelatinous, leukoplakic, pigmented, and even rarely diffuse variants. Corneal OSSN and corneal extension of conjunctival OSSN can be seen as a subtle wavy, advancing gray, superficial, convex corneal opacity, which is avascular or may have fine blood vessels. The characteristic features of OSSN include surface keratin, positive staining with rose Bengal stain, intrinsic vascularity, dilated feeder vessels. While presence of keratin is a characteristic sign, it is also important to know the aggressive variants like mucoepidermoid carcinoma that may have less of keratin and appears more nodular fixed lesions. Certain lesions that are seen in practice that can simulate an OSSN includes pterygium, actinic keratosis, squamous papilloma, pyogenic granuloma, conjunctival lymphoma, melanoma, and rarely allergic keratoconjunctivitis. Histopathology helps in the definitive diagnosis. Clinically, it is difficult to distinguish the spectrum of histopathological subtypes. Meticulous clinical examination and protocol-based management plays the key role in appropriate management. every case should be thoroughly, clinically documented to assist in the management. Although OSSN is a clinical diagnosis, imaging with anterior segment optical coherence tomography and ultrasound biomicroscopy provides valuable information in assisting in the management. For deciding the appropriate management technique, it is important to classify the lesions into localized, diffuse, or extensive or invasive OSSN. Management options in the armamentarium for the treating ocular oncologist includes primarily surgical excision with margin-free clearance and topical or intralesional chemotherapeutic agents. Others are radiotherapy that includes plaque brachytherapy, external beam stereotactic radiation, extended enucleation, or exentration according to clinical scenario. Surgical excision with no-touch technique is the standard of care.
This is a 4 mm margin that we delineate with the bipolar cautery. Cryotherapy is the most important step. It's a double freeze thaw. We go twice the margins. That's an AMG with the glue.
The excise sample must be sent for histopathological evaluation with appropriate orientation on a Whatman filter paper, wherein curling of the margins should be avoided. The report must include a comment on the margin and base of the excise specimen, whether free of tumor or showing positivity, so that correct protocols can be followed for further management after excision. Topical or local intralesional injection of anti-neoplastic agents is a very useful treatment option. Interferon alpha-2b is currently the most accepted and well tolerated with negligible local side effects. Systemic side effects include flu-like symptoms, and this is usually seen with intralesional injection. It is used as a primary immunotherapy or as immune reduction to reduce the size of the tumor, and also as immunomodulation in high-risk cases to avoid recurrence. Fluorouracil compounded as 1% solution can also be used topically 4 times a day for 2 weeks, followed by 2 weeks treatment-free interval that comprises of 1 cycle. Mitomycin C is yet another chemotherapeutic agent used for OSSN. Plaque brachytherapy is used to control gross or microscopic residual tumors. Clinical scenarios where plaque brachytherapy is helpful include cases of base positivity after excision. In advanced ocular surface squamous cell carcinoma with orbital extension, chemoradiation is yet another option. For intraocular extension, options for management includes extended enucleation. For cases with orbital extension, exentration is the treatment of choice. It is possible to provide good cosmetic rehabilitation in such cases. So with this, we would like to convey a strong message that it is important to know everything about a common conjunctival tumor that you may possibly see in your day-to-day practice, that is OSSN, or anything that simulates an OSSN. Knowing what to do and what not to do is so very important for accurate management and better outcome in terms of reducing recurrence and avoiding regional and systemic metastasis.
Yeah, this is like just another one on plaque brachytherapy. This was a patient with a large tumor over here. You can see there is a scleral fixity. And this is post-brachytherapy 3 months. So I'll just show you how we do a plaque brachytherapy. This is done in Malabar Cancer Center, Telcheri, Kerala. We have the plaque there. Yeah. So basically, wherever the lesion is, the base, the pathologist will be telling you that there is a base positivity there. And this is a ruthenium plug where there's an ethibond suture. So wherever you mark the surface, and then it's very simple. The procedure is so simple. It's hardly a 5 minutes job for an ocular oncology person, and depending upon the dose, you keep it for 1 day or 24 hours to almost 36 hours. And so that's how simple plaque brachytherapy is. Yeah, thank you. And I'm sure many of you are attending the International Society of Ocular Oncology. It's a biennial conference. It's happening from 3rd to 7th of this December. I'm going back there directly from here. Thank you so much. Thanks for your patient listening. Yeah.
Thank you, ma'am, for such a beautiful video presentation and
Thank you.
coming here when ISSO is so near in the brim. Thank you so much.
It's a pleasure, yeah. I can take questions if anyone has.
Ma'am, if the base comes positive,
Yeah.
so is there a role for interferon alpha to topical before we refer?
No, not at all. So interferon alpha 2b, even in a clinically primary case, it is not indicated for an invasive tumor. It doesn't work for invasive tumor. So when you talk about a base positivity, you're talking about an invasive squamous cell carcinoma there. So it's never effective. So if the margins are positive and it is not invasive SCC, then you can give as an adjuvant as topical chemotherapy for this patient. Base positive, it is radiation, yeah, and plaque is focal radiation. So.
Thank you. What about PAM, ma'am? Primary acquired melanosis. Do we sometimes the patient in the middle age ladies, they come saying the pigmentation is here. Do we have to biopsy it or observe?
Very good question. So PAM, the risk of PAM, basically we're all worried about PAM turning into a melanoma. It depends upon the clock hours. If it is 1 to 2 clock hours, you can easily observe. But if it's more than 1 to 2 clock hours, it's better to excise and look for ectypia. Now PAM coming in the phonesis, in the tarsal conjunctiva, in the caruncle is much more riskier clinically. Then I would definitely excise it and submit it for histopathology.
OSSN, you start topical based on clinical diagnosis, or you do cytology?
No, I don't do cytology. It's purely based on clinical diagnosis. Yeah, impression cytology, some of the consultants, they do it, but in my practice and from where I'm trained, we don't consider impression cytology gives much clue to the diagnosis, so I don't do it. Yeah. ASOCT on follow-ups.
One question. If cryo
Yes,
has
ma'am.
already been given to the base and the report comes as base invaded, still radiation is indicated?
Yes, ma'am, because base is really dangerous. Although you do cryo, there is no 100% guarantee that it's not going to invade the sclera. So if the base is positive, that means it can go intraocular. The recurrence is going to be very bad for the patient. So cryo, no. Okay. So we always radiate if the base is positive.
Okay, thank you. I have one more question.
Yes, ma'am.
When do you go for subconjunctival interferon therapy as chemoreduction, not the topical therapy?
Okay, ma'am, I started with topical in all cases, and then I found this. I have changed my practice pattern now. It takes time. Topical, 6 months, sometimes 8 months you have to go. So now in every case of mine, I give topical and also subconjunctival injection, and the resolution is like 3 months.
Okay.
So in order to get a rapid resolution, I use both in all these cases now, topical and injection.
Okay, thank you.
Yeah, thank you so much. Thank you.